Mitha is our next speaker. Ayoub is a pediatrician and a neonatologist at Lille University in France, and he holds a PhD in epidemiology from the University of Paris-Descartes and has a postdoctoral degree in clinical epidemiology from Karolinska Institute in Sweden. He will talk to us about long-term neurodevelopmental effects of skin-to-skin contact. Thanks, Ayoub, and the screen.
Thank you for the presentation. So on behalf of all the co-authors, present this study from the EPIPAGE-2 cohort study, supervised by Véronique Pira, and performed in the EPOPE research team. So next slide. Yes, so we know that skin-to-skin is beneficial for the physiological and behavioral stability of preterm infants and for breastfeeding and bonding between the infants and parents. But less is known about long-term impact. And this study has the objective to evaluate the impact of early skin-to-skin contact on neurodevelopmental outcomes at 5.5 years among very preterm infants. So the study is based on EPIPAGE-2 cohort study, which is a population-based prospective study of preterm infants in all maternity units in the 25 French regions in 2011. The population was 2,666 survivors at day 8 with gestational age between 24 and 31 weeks. And we performed a propensity score analysis with inverse probability of treatment weighting approach for the statistics. At 5.5 years, there were 2,561 survivors, and the outcomes were evaluated was cognition and behavioral difficulties. So our results of practice of skin-to-skin contact. In our study population, we had 1,607 infants exposed to skin-to-skin contact and 1,059 infants non-exposed. And we can see in these figures that skin-to-skin contact increased with gestational age from 24 weeks to 31 weeks. From D0 and D7, the first week of life. When we look at the practice of skin-to-skin contact among neonatal units, we can see that there is a huge variation of practice of skin-to-skin contact the first week of life in 2011 in France for the preterm infants from 24 to 31 weeks. And the practice of skin-to-skin contact among neonatal units varies from 15% to 100%. So now, with the propensity score approach, we try to have a balance between exposed and unexposed groups from different characteristics: maternal age, primiparous, the mother born in France, level of education, the socioeconomic status, living in a couple relationship, cause of preterm birth, tocolysis, C-section, anesthesia, multiple birth, gestational age, of course, sex, small for gestational age, the APGAR score, surfactants, CPAP in the first day of life, hemodynamics treatment, mother intent to breastfeed, the volume of patient of neonatal unit, and the NEED-CAP neurodevelopmental care training. And based on this, all these characteristics, we, after the propensity score, we all standardized difference between baseline characteristics is less than 10%. So the weighting creates a pseudo population with perfect covariance balance based on these characteristics. And at 5.5 years, we can see that regarding the full-scale intelligence quotient, the means cognition among the exposure infants, there is a trend for increased full-scale intelligence quotient. It's a black square. And when we look at the full scale above -1 standard deviation, there is an increased among exposed infants. And this effect is more, we can see that there is more effect among the population of very preterm, 28-31 weeks, and not in the extreme preterm. We have maybe two hypotheses explaining this difference. First, we have very low, few infants exposed to skin among the extreme preterm infants. And maybe there is still residual confounding measures. So this is our hypothesis regarding this difference among the study population. For the outcome of behavioral difficulties, there is no, we couldn't see some effects of skin-to-skin contact regarding this outcome and in all the population. So the strengths of these studies, we were able to evaluate the impact of skin-to-skin contact and long-term neurodevelopmental outcomes from a population based of extremely and very preterm births with standardized developmental assessments. Of course, we have limitation. We have no information about the duration of skin-to-skin contact and no information on skin-to-skin contact after the first week. And as I already said, despite a good balance between exposed and unexposed groups, residual indication biases or unmeasured confounders due to individual and unique characteristics may be still present. And there is always some intermediate factors. In conclusion, we can say there's a trend towards an association of skin-to-skin the first week of life with cognitive outcome at 5.5 years among very preterm infants. We can see that there's variability of practices among units deserves attention. And next step is evaluation of the dose effect is needed. Thank you for your attention.
Thank you so much, Ayoub, for this very, very interesting presentation. I'll quickly jump into the questions. I've got a couple of questions here already. So the first one concerns the difference between skin-to-skin care and kangaroo care. What's the difference between the two? And how did you define skin-to-skin care? For example, in terms of days, hours of the day, and at what time was it initiated?
In this study, the skin-to-skin contact was not defined as a minimum duration of skin-to-skin contact. So it's skin-to-skin contact the first week of life, but we have no information about the duration and the timing, the specific timing, which day the skin-to-skin was performed the first week of life. And the difference between skin-to-skin and kangaroo mother care is that for kangaroo mother care, infants stay more than 18 hours a day with skin-to-skin contact. So it's a longer time of skin-to-skin contact.
There I am again. Thanks for the answer. And what was the rationale to do the evaluation at 5.5 years or 5.5 years of age? Or why did you choose that age? It's good to see a long-term evaluation, by the way.
We know that if even the neurodevelopmental outcome at 2 years is limited, and at 5.5 years, we have more information and more detailed information about long-term neurodevelopmental outcomes, and it was already designed in this in the EPIPAGE-2 cohort to do this specific and standardized evaluation.
Okay, thank you. Well, there's a lot of questions, but unfortunately, I just give you one last. What other implications? How can you transfer your findings to limit to context poor settings, to resource poor settings?
We know that skin-to-skin contact has many beneficial in the short-term outcomes, and this study brings more knowledge for the long-term impact. So it brings more confidence to this practice. There's many beneficial actions for skin-to-skin in the short-term outcomes and for the long-term outcomes, and particularly in this vulnerable population of preterm infants.
Thank you very much.